Yeah, yes, sir. So that's again a very important question, particularly setup like ours where acute infections are quite common. We need to differentiate at the outset, and we need to judiciously use lab as far as investigations are concerned. So um, what we do in our unit and most of the units probably as a tier 1 and tier 2 investigations. So at the outset we would send a hemogram and systemic inflammatory markers, whether CRP and if procalcitonin if available. Probably these two will give us an idea whether the child has elevation of um, evidence of systemic inflammation and possibly lymphopenia or a borderline thrombocytopenia, which suggests MIS-C, as compared to some of our tropical infections like dengue or scrub typhus, where you get a profound thrombocytopenia and a leukopenia to the extent that the total count is quite low as compared to what we have seen in MIS-C. So these are the markers initially to distinguish subtly between an infection as well as from MIS-C. And if the clinical features along with mucocutaneous signs or GI manifestation which points towards MIS-C more favors MIS-C, then probably we would do this next tier, which includes the coagulation abnormalities and cardiac markers of cardiac inflammation and echocardiographies.
Yeah, to add to that, I would say, like Karthi has already highlighted, and I would just say that it all depends, Dr. Amyan, that in which phenotype the case has presented. Actually, we all know that KD has various, MIS-C has various phenotypes in which it can present. It can present with shock, it can present with MODS, can present with KD phenotype, and it can just have some simple febrile reaction and nothing else, just with fever and some irritability, and that's it. So investigations basically are focused on, like if a child is presenting in shock, then we do all the investigations in one go, including tier 1 and tier 2. So because there you want to diagnose it early and hit hard. And if they're in simple coming in your OPD or a clinic just with fever and mild other symptoms, so maybe we'll just do a complete blood count and a CRP and some liver function tests and also rule out other infections. So that's how we'd go forward in our management.
That's great. Thank you. And, as you guys were talking, I was thinking, in the case also, you start with your pretest probability of something, right? And you have to know what the prevalence of disease is with what's happening. You take your laboratories, your exam, you start down a path, and then you have to be prepared if that's not working to change strategies, and you use what you can use. And I like, I think of our prone patients who are in ARDS who we can't get an echo or we can't get good views. And we are using our exam, and are they cold and are they warm, and do we think they have capillary refill, and those things, even when you have the most technology available, are still, I think, a foundational part of being able to make your diagnosis. I wanted to ask, there's a difference, and I'm coming at this from an adult standpoint. And actually, I want to go back for a second, just for everyone's aware. So milrinone, we talked about it in the case, but so people are aware that's a phosphodiesterase 3 inhibitor. That's an inotrope and a peripheral vasodilator. That is sort of a primary inotrope for cardiac shock. And so just so people are aware, that's really a therapy for cardiogenic shock. And it's a little bit different than our standard vasopressors. So when they added that milrinone, that was sort of we're now treating for cardiogenic shock, which is a different therapy than sort of our fluids and vasopressors for septic shock. And so just to clarify that, but I also, in adults, when I think of the COVID patients that have been coming in, a mainstay really is their PCR nasal swab positive? And that is sort of what we use to diagnose and then treat it and go down the pathway. It seems that in children, the strategy might be a little bit different, and you're using some indirect markers. And so I was wondering if you guys could talk a little bit about the difference between the adult patient that comes in COVID positive, ARDS, progresses to multi-organ failure, versus the child that comes in, and how that sort of history and their testing might be a little bit different.
Yeah, I think that's an important question, Dr. Souvik. But the pediatric presentations are quite different than the adults. In children, usually it's the pediatric COVID pneumonias are not very commonly seen. They usually present with GI symptoms, which are common, or they present with some skin findings or some other symptoms. And they are very mild. They don't go into ARDS very commonly. We hardly have seen COVID pneumonias. Very few percentages are there in the pediatric patients. And that's why MISI, the commonest problem which we have seen in COVID patients are this post-COVID MISI, which is there, that's been loads which you have seen. And though in MISI also you can have RT-PCR positive, but majority of them were basically the antibodies which were positive in them. So there is a different presentation than adults totally in the pediatric patients.
Yeah, I would agree. And that is, again, a very good question because as Dr. Bansal was saying, that they present differently and we don't have a marker that we can immediately get results in. If their COVID is negative, and as many of these children present about 4 to 6 weeks after their COVID infection, we were relying on possibly their COVID or their antibodies for a history of COVID being positive. A lot of children will have a COVID infection and not have any symptoms from it. So we can't even get a history of having COVID or any viral infection in the recent past that would help us increase that pretest probability. The easier patient, as Dr. Bansal even said previously, is the one that comes in that is sick and shock and that we are doing everything for and is higher in our differential. The harder child is a patient that presents a little bit more abnormally, possibly like KD, that could also look like other viral infections. And those are the ones that we have to have a high level of suspicion to move forward on.
I would say that, I was going to say that here in the US, we've also had such significant community spread. As I suspect, it's also the case in India, that originally the CDC definitions were requiring that, without a definitive either antibody testing or PCR testing being positive, that there was a known contact. But that has largely changed, I think, over the past 6 to 9 months, because we are seeing such a high degree of asymptomatic community spread that, as Dr. Hussain said, you just have to have a very high index of suspicion for the varied clinical presentation. And so in many cases, we are presuming MISC until proven otherwise, in particular because in our institution, it does take sometimes up to 48 hours for the antibody testing to return. So we are often presumptively treating even prior to having definitive antibody testing results.
That's good to know, Nicole, that earlier we were thinking it's only here that we are taking 48 hours for the test, but
That's
Can I
great.
ask a
Thank you, guys.
question about the concern about myocarditis in COVID vaccine individuals and whether that complicates the differential as we're expecting more children to have the vaccine available to them? Nicole, what are you predicting?
Yeah, thanks, Bhakti. I'm going to speak a little bit about that in the evidence-based review at the end of the presentation. But yes, we are seeing more and more myocarditis, specifically after the mRNA vaccinations in the 12 and older age group. There has been a definite male predilection, male predominance in many of the case series. So again, we're having a high index of suspicion if we have male adolescents who are recently vaccinated. We're seeing it predominantly after the second dose of the Moderna and Pfizer vaccines. So I do predict that we will see more of this. We've seen case reports and case series coming out of Israel and now here in the US as more and more adolescents are being vaccinated. So, these are being reported to the VAERS system as adverse events. However, I think there's not really enough data to say conclusively, about a causal relationship, but the CDC definitely has their eye on this, I think, here in the US. I'm curious to hear from my colleagues if you're seeing this more as well in your populations in India.
Abhijit, do you want to comment on this? Have you seen any case with vaccine-associated myocarditis?
No, sir, not seen here.
No, I think Nicole here, we haven't seen here the myocarditis with vaccine, probably because we're not using the mRNA vaccine at present. So maybe that's one of the reasons.
And
What
still in
makes
India,
it-
vaccines are given to adult age group who are more than 18 years.
Yeah, I think
for
for
us
us,
over
it's
here-
become a difficult part of the differential because some of the patients are presenting similarly to MIS-C patients. However, they're typically not febrile. So that's been the big difference for us.
Yeah, and what also
in
makes it
terms of
easy is that these patients are also having the myocarditis from the vaccines, usually within a few days of having received their second vaccine. So having and knowing that history, and they're typically aren't presenting as sick when they present as some of our sick MIS-C patients. So it does give us a little bit more information than the MIS-C. So a little bit easier to differentiate than the MIS-C from other things.
That's great. Thank you guys for all that. I think that's really relevant for us to understand. And the time course is very helpful. Obviously, the history is oftentimes how we're getting to our diagnosis. We've had a couple questions in the chat, and I did sort of want to summarize this. And unfortunately, I guess, steroids in medicine, right, is this gigantic pendulum that swings one way to the other. And so there's a couple specific questions. I'll start with one that I had, which was the panel sort of thoughts and timing of steroids, and there's a couple things. It's sort of the initiation, it's how long to continue, and then if there's any role in sort of the milder cases. And I think I'll start, maybe Dr. Bansal, if you want to take a crack at it, and then we can get everybody's sort of opinions.
Yeah, that's a good question. Steroids is the enigma, actually. When to start, the dose and all. So I would say, like, if a child has come with a multi-organ involvement or in shock, so I would give it as soon as possible. So that's the earliest I would like to give, because IVIG takes time to procure. I think in any kind of setup, it's not easily available. But methylprednisolone or any kind of steroid, it's easily available. So if your child is in shock or is in KD phenotype, give the methylprednisolone as first drug. But if he is presenting with mild disease, I'll not give him that. I'll just wait and watch and observe for 3 to 4 days at least. And also monitor him daily and see if it's worsening, then I will see and decide about steroids. But if he's not, then I'll see whether the fever is high grade, it's persisting, the CRP is increasing. And whatever our experience here is that if the pain abdomen is very specific, if the pain abdomen is increasing in a child with mild disease, that's the case which we've seen worsens very fast. So in those cases, I think we should be acting early and giving methylprednisolone if they have a severe abdominal pain. So, and then is the dose. Usually we give either 2 mg or 10 mg per kg. If a child is in shock, we give 10 mg. Otherwise, in KD type or other conditions, we give 2 mg per kg of steroid. We don't give 30 mg or higher doses. So maybe others can comment on this, Abhijit or anybody else.
Yes, I agree with you, sir. We are also following the same protocol. We start with children who present in shock. We give 10 mg per kg for 3 to 5 days. And then we change over to oral prednisolone and taper it over the next 3 to 4 days. Whereas in children who don't present with shock and whom we give steroids, we start with methylprednisolone 1 to 2 mg per kg per day. We give methylprednisolone for 3 to 5 days, and then we change over to oral prednisolone and taper it over the next 3 to 4 weeks.
Yeah, our practice at Johns Hopkins and our ICU is quite similar. Our rheumatologists usually help us determine the length of treatment, but I think it's been very similar to what my colleagues have mentioned. We will usually do a minimum of 72 hours of IV high dose and then begin to taper down. Usually they will use the biomarkers, specifically the BNP and the CRP when available, to identify the decision point to convert over to oral steroids. The American Society of Rheumatology has been recommending in many of their publications a very prolonged, slow taper, oral taper over several weeks. for any children that have presented in shock and or with any echocardiographic abnormalities. So typically these patients are followed over the long term outpatient. I know that can be a challenge in some settings, but typically our rheumatologists and cardiologists will help with the outpatient taper over the course of the subsequent 4 weeks after discharge from hospital.
That's great. Thank you both for that. And I think